Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamines, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG Oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
A 50-year-old post-menopausal woman with a T1C node negative invasive ductal carcinoma of the right breast. And this is ER/PR positive as well as HER2 positive. She had an excisional biopsy with a 2-millimeter negative margin and a negative sentinel lymph node biopsy. And the questions that are being posed are, should this patient undergo additional surgical resection for potentially a wider margin status? And the other question is, what radiation therapy regimen and systemic therapy are indicated? So this patient, good performance status with hypertension. She has menopausal, G0, P0, no hormone replacement therapy. Her bilateral mammogram and ultrasound demonstrated architectural distortion at the 11 o'clock position in the right breast. She had a core biopsy in July of 2020, which was sort of inconclusive, showing fibrocystic changes and atypical ductal hyperplasia, which prompted an excisional biopsy. This demonstrated atypical hyperplasia as well as invasive ductal carcinoma, which was ER 90%, PR 90%, and HER2 HER2 positive, Ki67 of 10%. The margins were negative with 2-millimeter margins. In later that month, she had a right sentinel lymph node biopsy. There were 2 sentinel lymph nodes identified that were negative. She underwent a mammoprint, which demonstrated low risk luminal type A results. And she had a staging scan with the CT chest, abdomen, and pelvis, which was negative for metastatic disease. So we might have, first of all, Dr. O'Shaughnessy, would you mind commenting on the sort of discordance between the HER2, what was reported to be HER2 positivity, and then the mammoprint showing low risk luminal type A disease?
Right. So the first thing you say is, oh gosh, that's discordant. That's the first thing you want to do is make sure it all hangs together. And this really does look like an ER-driven breast cancer. Now, some of them can have HER2 amplification within them, but I would be skeptical of the HER2 results. And so I'd want to see them. So for example, some caveats are that the main antibody that's used for HER2 IHC is called 4D5. And according to Mike Press, who's the, in my opinion, the guru of HER2 testing in the US, the 4D5 antibody leads to an overestimation. The titers are such that even low levels can be read as 3+. So it tends to overcall the amount of the HER2. So many times he has his own antibodies, and many times when he redoes it, a 3+ turns into a 1 or 2+ actually. And then the other thing is looking at the HER2 FISH very carefully. If a FISH wasn't done, for example, I would ask to have a FISH done. And again, if there's discordance there, what I generally tend to do is I tend to send these. These are very important decisions for the patient. I tend to send these to Mike Press. He's got a very large reference laboratory at USC, very easy to access, et cetera. Because I really, really have found him to be, in my mind, just really spectacular at redoing the IHC with his own antibody and redoing the FISH. He's just so because I suspect she'll come back HER2 negative, I suspect, but it's possible she may not. She could have some low level HER2 amplification. She could be at the 2+ and have some low level amplification.
Okay, thank you for that. Dr. Jogelson, do you want to comment about the imaging?
Sure. What we have here are 2 views. I guess they flipped the breast because pointing like a left breast, but I think it's just they're flipped on the images here. And you can see the arrowheads, which demonstrate, and it's pretty dense, but you can kind of see some architectural distortion here in the outer portion of the breast, and it's probably sitting in here. She's a tough breast to look at. And this is also a CAD image, so this is computer-aided detection, or maybe now it's artificial intelligence, the next step of that. But you can see the star here as the machine tells us to pay attention to something else. And what it's showing you here is a circumscribed mass, which I'm guessing somebody's already worked up, and it looks like it's benign. The problem with CAD is sometimes it shows you things that are not relevant, but this is the area of the cancer.
Thank you so much. Dr. Ramones, do you want to comment for us about her margin status with the 2 millimeter margin with atypia and invasive disease?
Yeah, no, I think that I would feel comfortable with the margin based on the the margin consensus panel. I think no tumor or NINC for invasive cancer is appropriate, and she has a couple millimeters, so I would not recommend any additional surgery for her. And again, 2 out of 2 negative nodes, center nodes, I think that's fine. So I would not recommend any more surgery.
Perfect.
We don't know her tumor size. We don't know her tumor size. I don't know if it can be estimated from the mammogram. We just, it looks small, like maybe a T1 type thing, or?
Yes, my understanding was it was just a little over a centimeter.
Okay.
And Dr. Vicini, what about radiation for this particular patient?
I would recommend either accelerated whole breast irradiation or conventional whole breast irradiation, plus or minus a boost, probably add a boost. In this setting, I don't think this patient really would qualify for partial breast irradiation, or certainly wouldn't be my optimal choice.
Why is that, Frank?
I'm not certain. This was an excisional biopsy per se. I'd have to sit down, talk to the surgeon, look at the pathology, feel a little bit more comfortable about the margins for partial breast and the patient age. I don't like to push the envelope for partial breast.
It also looks like it could be near the skin.
Yeah,
you'd have very little room.
Right.
At least
well, if you did a brachytherapy technique nowadays, though, we are using more external beam techniques, following just 5 fractions over 5 days, like Dr. Levy did in Italy. There's a lot more of that going on, 6 grade times 5. And certainly the proximity to the skin in that setting isn't an issue. But again, I prefer to just use the standard therapies and not push the envelope for partial breast.
Okay. Dr. O'Shaughnessy, what are your thoughts about systemic therapy? Thank you for the insight you've provided us about trying to clarify, of course, the HER2 positivity. That's going to be critically important. Assuming that you can clarify either through FISH or through a second opinion on the pathology, and that this is found to be HER2 negative, what would be your systemic therapy recommendation?
With the 70 gene signature, low risk and luminal A biology, all of which is concordant with what we see clinically pathologically, I certainly would just go with endocrine therapy alone for her. She's 50. Her last menstrual period was 47. That's close enough, that I'm still worried about some ovarian function, and I would get an ultrasensitive estradiol and FSH, because the question is, do you just play it safe and go with a few years of tamoxifen and then switch her over to an aromatase inhibitor, or do you go in with an aromatase inhibitor? I think you're obligated to follow the estradiol and FSH levels, just because the ovaries, even though the definition of menopause is no periods without any interventions for a year, and she certainly meets that, but we know that there's a gradual fall off of ovarian function over 10 years or so. So I am cautious about aromatase inhibitors in women in this age group. And so I would talk to her about, either way, tamoxifen. I'd be very comfortable with tamoxifen followed by an aromatase inhibitor, likely for about a total of 5 years, probably.
Okay. All right. Perfect.
Now, I guess I could go the other way too, just, for interest, what if it's HER2 positive? What if it's HER2 positive, right? What do you do here? So here is really where I use the APT regimen. this is where I really feel the cancer is more about the estrogen receptor than about maybe a low-level HER2 amplification. And I would utilize the weekly paclitaxel times 12 with trastuzumab, and then of course endocrine therapy. Let's say somebody was diabetic and they had very bad neuropathy and such from the ATTEMPT trial. We've seen equivalence with TDM1. The problem there is a whole year of it seems like too much. On the other hand, those are the data we have is with a year, but I might that would be the only time, though, only in the setting of very significant neuropathy where I wouldn't want to use the paclitaxel. Otherwise, I would go with the paclitaxel, trastuzumab, finish out the year of trastuzumab, and then, of course, bring the endocrine therapy in after the paclitaxel.